Hello. Hello. Good morning, all. Am I audible? Hello.
Hello. Yes.
You are
Yes.
audible, sir.
Uh,
Hello. Good morning, all. Today we have two interesting topics on endoanal endosonography and the US is even though very frequently practiced across many centers nowadays, and still endosono of endoanorectal US is still less frequently practiced by gastroenterologists. Most of the cases, in particularly in perianal region, we refer to the radiologists who are expert with that specialty. But it is one area which is still need further education and evaluation to enlighten us. Mainly, we have two eminent speakers today. One is Dr. Madhura Prasad and Dr. Vikram Bhatia, and who speaks on Dr. Madhura Prasad speaks on the endotherapy in the rectum, and Dr. Vikram Bhatia, who is a eminent endosonologist and a senior consultant at ILBS, and who speaks on the anatomy of the anorectum. Now I request Dr. Madhura Prasad to speak on endotherapy in rectum. Hello. Hello. Yeah.
Can you see my slides, sir? Can you visualize my slides? Give me 1 minute, sir. Let me just check.
In this way, we have two sessions, and each session lasts for 20 minutes, and followed by 20 minutes of the discussion. Dr. Madhura.
So, thank you very much for this opportunity. I'm going to talk on endotherapy for colorectal lesions. I'm Dr. Madhura Prasad from Coimbatore. So, I'm just dividing it into two, polypoid lesions and colorectal bleeding. Let's look at polyps. The Kudos classification is what we generally, and it's very easy to use. So, we're going to first assess the polyp. Does it have a regular round pit pattern? Then it's probably just a normal and astroid or papillary pits. This way, it's probably hyperplastic. These two you can safely do whatever you want. Here, this is small tubular or roundish pits. It could be an adenoma, but more likely when we see these kind of elongated pits, right, or branch-like or gyrate pits, it's more likely to be an adenoma. And when there is a loss of the mucosal pattern or a loss of structure, then it's more likely to be adenocarcinoma. Look at this bizarre appearance. Nice classification also gives it very nicely. Here you see that nice classification divides it into 1, 2, and 3 types and takes into account the color, vessel, and the surface pattern. Why do we need to know all this? Because that is going to help us decide how deep we are going to cut. If the polyp has a peduncle, it's very easy. That definitely there's not going to be any invasion if the peduncle looks very normal and not involved, the NBA pattern. But if it's a sessile polyp, then we have to go in and assess what we're going to do, pre-plan it, even use an EUS endo ultrasound, help to find out which layer is involved. Now let's see the color, vessel, and surface pattern. As we know, the NBI can predict which layer is involved. It's just a mucosa or a submucosa or muscularis propria involvement. That there are very well documented ways of differentiating. Now, if you see here, is it a light color like this, or is the color? Look at the color of the background is going darker, and the vessel pattern is very regular to irregular. If it is elongated like this, it's more likely to be an adenomatous pattern. And here, this is bizarre. This anybody can differentiate, right? So then the background surface pattern, we're going to differentiate and then proceed. Now, is there a superficial colorectal neoplasia? Is it non-pedunculated or pedunculated? If it's pedunculated, look at the stalk size. Is the head size small and the stalk thickness less than 5 millimeter? You can do a hot snare polypectomy. This is a little older article. You can also do a cold snare according to the, based on the stalk thickness. We always prefer a hot snare polypectomy, but cold snare is coming into vogue right now, so I want to discuss that later. Let's see the head size more or the stalk thickness more than prophylactic ligation of the stalk using a detachable loop or clips and then safely proceeding. Is there a non-pedunculated sessile polyp? Now, this is where we need to do the imaging, find out if it's diminutive, small, or large. Large polyps are what we're going to decide what we're going to do, right? So if there's a large polyp, and endoscopic imaging, we need to know if there is a submucosal invasion by endo ultrasound. Easily we can see if the muscularis propria submucosa is invaded. What's the other way of differentiating of involvement directly on the spot? The lifting sign. Very easily done. You just inject saline. If there is a good lift, most likely you're not going to be seeing any invasion. We do not usually resect lesions which have a non-lifting sign. We don't go for it, or else we alert the surgical team, look for the depth of invasion, alert the patient to the possibility of breaching the muscularis propria, and also the most importantly, if we're going to go with such a lesion, we might leave some tissue behind, which is going to be, there could be a recurrence or a unknown malignancy in the depths. So it's better to have the lifting sign before we proceed. Here, there's a non-invasive lesion, which could be intermediate size, 10 to 19 millimeters. You can decide for EMR for non-polypoid or suspected serrated lesions, or a large size, go for endoscopic mucosal resection. And we have to resect as much as everything. All the visible lesions should be resected. Suspected submucosal invasion, we can go for EMR or ESD, and suspected deeper invasion, please go for surgery and don't attempt. Yes, as I said, lifting sign is very important. Let's look at this video. I just want to show you how this is an older video. It's a wonderful teaching video, but I definitely want to show this. So I'm going to share another screen. It's a good teaching video. I want to show all the different techniques in one single video. So I want to share this one. I'm going to reshare my screen a bit. See, that is the standard polypectomy, which is going on, where the stalk is, the peduncle is injected and the snare is used. Always rotating the scope to bring the polyp into focus. So you know now why I wanted to show this video. My guru and my father, Dr. V.G. Prasad, is here demonstrating. And all his students love this, so I just wanted to show it. Injection into the base, lifting up the whiteout over there. Definitely shows us that we can go ahead. and garlanding the polyps, bringing the polyp into the 6 o'clock position is definitely going to be useful. Hot biopsy forceps, we use it for tiny polyps, which and the base has to be cooked until to destroy any tissue there. And always when you do the polypectomy, it is good to bring the polyp after garlanding it, bring it to the center of the field, away from the mucosa to avoid any injury to either end of the mucosa. Here we are having a thicker pedicle, so we're going with an endo loop and going around it and tightening it at the base. You can see how very well the demonstration of how to deploy an endo loop there. Yes. So after that, the Americans have a way of resecting below the endo loop, but we always go above the endo loop and leave the loop in place to prevent any bleeding. Well, they like to remove entirety of the lesion, so they usually go below the loop, but we go above the loop. So you can see us removing to the Rothnet, and this is one of the complications of polypectomy, bleeding, where we're going to clip here. So a hemoclip is being deployed here to clip the base. It's always better to visualize it for a while and then come out. Yes, and always better to anticipate, inject, raise, and even beyond that, you can see how thick the pedicle is. I'm going to stop that and go back to my presentation. So, cold and hot snare polypectomy. What they're worried about is, one is the damage to the mucosa. So delayed bleeding occurs more after hot snare polypectomy. Now, 15 patients underwent histological evaluation. So what they did is they saw after polypectomy, how did the histology look? And cold, all the depth was only up to the shallow submucosa. Whereas in hot polypectomy, there was some depth damage, which is what they demonstrated. So what we generally do is we pull the after garlanding the polyp, we pull it away from the mucosa and then snare it off. So even though we have not seen much of delayed bleeding, this is what is advocated. Try to do cold snare as much as possible, that's what they say. Now coming to the next patient, is a 63-year-old lady with a distal rectal growth, and the growth came as, histopathology came as tubulovillous adenoma. The CECT showed no invasion, no perirectal staining, because it looked very malignant. They went for a CT scan, everything was normal, and they referred for an endoscopic submucosal dissection. Here there is, you can see it's a large one involving more than half the circumference, and we had to do it in 2 sittings, the ESD, and you can see Dr. VGM resecting it here. He's going to the base, and what's important in the colorectal lesions ESD is the curves and the twists of the colon. So going with the plane is very it has to be very carefully done because of the turns of the colon, and this lesion was at such a junction. And you can see the white knife was the IT knife, the IT nano knife, and then he's going in he uses basically the IT nano knife more for dissection. And you can see the base where we are spraying collagen. Collagen helps in healing, and this is his own invention, and he uses it a lot. Now you can see here in 3 months there's wonderful healing, and one area alone there was some dark brown color of NBI, so we went in and biopsied it, and that came as just kudos. I mean, it came as an adenomatous polyp. After that, we still had the patient under surveillance, the same patient at 1 year, and again there was a small polyp, but it did not then entirely normal at 2 years. So this patient is doing very well now after resection. Here is a patient where we did not want to resect actually. The patient had a and it was not involving the muscularis propria. And the patient was advised surgery, but he was 90 years old, and he had extreme difficulty every time during when passing motion. He was actually having a lot of discomfort because of the growth being right next to the anal verge. So he wanted it to be resected. This was done 2.5 years ago. I did this resection. It was all planned by a surgeon in their family. So look at this. We are dissecting from the base. I think the video is not playing. Yeah. From the base, you can see the muscularis propria here, and very carefully we resected. Obviously, there were a few spots of involvement, and we did APC at that point. This also took almost 4 hours plus 4 hours. We did it in 2 sittings. And here, this is the final resected area where this is the APC where we've done APC and then we sprayed collagen. And fingers crossed, the patient is still doing well after 2 years with no recurrence. Now, this is the next case. It's a 68-year-old gentleman with loss of appetite and weight loss. It's an unusual patient. He came with a PR bleed also. Actually, imaging showed metastatic lesions in the liver, and the largest was measuring 8 by 5 centimeters. And we went in for the biopsy of the liver. The liver lesions were biopsied. The liver biopsy was suggestive. It was very confusing. Some of them we went with two pathologists. One said it is a hepatocellular carcinoma, and the other one was of the opinion that it could be a metastasis, cholangio, or hepatocellular carcinoma. So, not being clear about what it was, we went in to see the rectal lesion, which was identified on CT abdomen. There was a distal rectal polyp. So, the rectal polyp looked like probably a submucosal lesion. We went in, we did an EUS. It seemed to be arising from layer 2 or 3, and no infiltration of muscularis propria was there. And I did this EST here. Like we mark the lesion around, and then after marking, we connect the points. Now we're using a TTJ knife. So here again, the lesion was lifting very well from the base, you can see. We use indigo carmine, and also we use hydroxymethyl cellulose to raise the lesion. Now there are other different agents which have come to raise lesions and keep them lifted, which is very important for ESDs. So here, this indigo carmine helps to differentiate the muscularis propria and the rest. The muscularis propria will be visible as a nice white layer. It's important for the diet to not be too concentrated, because then you'll not be able to differentiate the muscularis propria from the submucosa. We can also tunnel into the lesion and then go and resect, or we can continue to resect on all sides, and then finally the base is resected. When resecting the base, it's better to visualize, because there will definitely be one stalk which will bleed a lot. Now you can see the base where the muscularis propria is there. And I think this procedure took around 2 hours to do. And we are any large vessels at the base, we coagulate it and then spray collagen. And so that is how this patient, it turned out to be neuroendocrine tumor. And then the immunohistochemistry was done for the metastatic liver lesion also. It also turned out to be the same neuroendocrine. So it is metastatic neuroendocrine. Generally in neuroendocrine tumors, it
It's not audible.
So I'd like to play those videos which were not played. Can you allow screen share, please?
Yeah, ma'am. I'll tell the technical team to allow it.
Thank you, sir. I'm waiting. Not yet. Yes, it's allowing now. So this is the video which we just wanted to demonstrate. So that is the rectal which came out as neuroendocrine tumor. Am I audible, sir?
Yeah. Yes,
Okay.
ma'am.
Yeah, ma'am.
So
Yeah.
here we are marking the lesion, and first raising the lesion and then joining the dots together. Either we can go under the lesion or we can go around it, all around it. The only problem with the rectum is the angles, and because of that, we will not be sure of which layer we are in, right? So it's very important to know which angle we are going at. And so we generally use the IT knife to be very safe because you're not going to damage any tissue beyond, especially when we are going under the lesion, we use the IT knife. So the indigo carmine helps to differentiate the muscle layer, which will not be stained blue, and then the submucosa will be stained blue. And at the base of the lesion, we can anticipate a large vessel mostly, very, very commonly, especially with adenocarcinomas. The tubulovillous adenomas, we see a thick vessel at the base, so we should be very careful there. And we generally spray collagen at the base and coagulate all the vessels and spray collagen. This helps to promote healing, and also we all our repeat patients, we've seen very good healing with that. So I'm going to go off the screen, Shan, and you can continue the video, sir. The organizers, you can continue the video.
Yes, ma'am. Yes, ma'am.
Yes, sir. Thank you.
It has been seen that if you remove the primary, the metastatic lesions also start to disappear. Even this patient is doing very well now. And we did a gallium DOTA knock, which showed only a liver activity. And the patient is undergoing PRRT, particulate therapy. Now, coming to other things, malignancies and other complications in colon, colonic SEMS insertion. Colorectal SEMS stenting technique is simple. You're going to insert most commonly we use an uncovered SEMS, and it's important to have a fluoroscopic guide, and there are through the scope stents, so we can have direct visualization and insert them. And that radiologically also they say they insert them, but we here do it properly under visual and fluoroscopic guidance. So here we pass a stent and guide wire contrast injection to make sure that it's in the right place and not a false somewhere else false tract, and a partial stent deployment, pull back, and then you deploy the entire stent inside. Here the SEMS available. This is an uncovered wall flex, which is most of them have diameter of 2 centimeters, which is important because the colonic because the left side the stools by then when it comes it is firmer stools, so you need a larger diameter. Fully covered Nitti stent, so they're all stainless steel or nitinol, and this is the uncovered wall flex stent. So here it is important. The main thing is again the colonic bends and curves. Very important to make sure you're in the lumen. So injecting contrast the guide wire
just enable sharing.
into the lumen. And we are going in, even sometimes we put in a pediatric scope to go in and see, but most of the time it's very difficult to do that. So we put the guide wire contrast, check, and then deploy. You can see the stent being deployed here gradually, and that is the end. Definitive surgery is there. But it's not, all the studies are showing a higher rate.
Can you
but
screen sharing?
For an aged person and to avoid it, so multi-step surgery, this is a wonderful help. And after the duration of the surgery, you can plan 5 to 10 days after the stent insertion, because you need to allow the dilated loop to recuperate. And palliative option for
yes, I'm just sharing. Give me a minute. Oh, sorry. Just give me a minute, sir. I'm so sorry for all this. Yeah. Now you can see it, sir?
Yeah, ma'am.
Yes. Yes. So here we are passing the uncovered SEMS deployment care. We looking at it fluoroscopically. You can see the deployment from the proximal to the distal deployment. You can see as the stent is expanding. Now that
carcinoma sigmoid colon? Sigmoid colon.
Yes, sigmoid, sir. Yes, sigmoid. Yeah, I'm going to stop sharing again. You can continue, sir.
Yes, ma'am.
Incurable left-sided obstructive colorectal cancers, yes, you can do it as a palliative option as well. And if you use a covered SIMS, it's going to migrate. So it's better to use an uncovered SIMS. And right-sided colorectal cancers do not require any stenting because the stool is actually of a liquid consistency in the right side. So colonic strictures, balloon dilatation. So this is a patient who's a 54-year-old with a known case of colorectal cancer who underwent surgery and chemoradiotherapy, rectosigmoid growth. And she developed stricture at the anastomotic site. We didn't know if it's due to radiation or was it an anastomotic stricture. So she had a colostomy still in place. So we went in for a dilation before to stoma reversal. So here, this is actually the second sitting. The first sitting, we couldn't even identify this. This area is not the root. We went in with a baby scope and saw, but the pediatric scope, no. This, the lower one, is actually the opening. And after 2 dilatations, we could visualize it clearly. We went in with a pediatric scope, and we could go into the colostomy as well. I'm going to stop here. The differentiates the colonic stricture. Benign, diverticulitis related, it could be Crohn's disease, can be radiation induced, infective, ischemic, could be a malignant stricture, which we have to really look out for. And pseudostricture can be a volvulus or an intussusception, which presents like a stricture. And you look at it, it looks like a stricture, but it could just be any of these also. Colorectal bleeding, let's come to the next thing. So rectal variceal band ligation. So here, when do we suspect colorectal bleeding? In a UGI bleeding, if the patient entire esophageal varices and fundal varices appears to be in a portal hypertensive bleed, appears to be normal and doesn't seem to be bleeding from there, and the patient has fresh blood per rectum, then we have to suspect. Many of them, sometimes they don't look evident on endoscopy, but they could still bleed. So EUS assessment is also coming up for evident and non-evident rectal varices. And let's see how they are actually formed just for an academic purpose. Here, the superior rectal vein is coming down, joining the inferior and middle rectal veins so this is coming from the portal circulation, this is from the caval circulation, and here the varices are formed. Now, what's important here is it is the reverse of an esophagus. So up, down, and down, up is reversed here. So here, the first band is applied above and the second band below. And if you see the zones in the rectal venous circulation, there is an inflow zone, a downflow zone, outflow zone, and see all these zones. So that let's say the inflow zone starts, the outflow zone in the anal canal starts 1 to 4 centimeters, and then 4 to 6, 2 to 2 centimeters, these zones are placed, just equivalent to the gastric zone, the palisade zone, perforating zone, and the truncal zone of the esophageal varices, just to show. Now, coming to rectal variceal bleeding. So here you can see this video, I think it's not playing. I'm going to skip it, otherwise I have to log out and log in. So here, this is rectal varices. What are the options? The treatment options can be banding, sclerotherapy, cyanoacrylate glue injection. It is not very clear, and the only problem is there can be recurrence. And if there is a incessant bleed, you can go for TIPS or BO, and surgery. Surgery is, of course, the last option. Mostly we'd like to go for a TIPS or a BOTO. And surveillance, it's better to do it once in 3 to 6 months. Here are other lesions, the small bleeding lesions. You can do a gold probe, I think. So that's another one. Radiation proctocolitis also a cause for bleed. It's becoming less and less because of advancement in the radiation therapy of cervical cancer. So here, we have to assess the patient for proctitis. Is it acute or is it chronic? And we're going to look at that colonoscopically. We're going to check, and the grade. So mostly what we see, the bleeding will be in the grade 3 or 3 is what we generally see, and we manage them with endotherapy and anti-inflammatory agents, antioxidants, sucralfate enemas, And hyperbaric oxygen therapy, short chain fatty acids, these are all other therapies. And basically, endotherapy, we're going to do APC, formalin gauze therapy, or laser coagulation. But continue to reassess based on symptoms. If there are severe painful symptoms, the patient will need to go for a surgical intervention. Thank you very much for this opportunity. So the take-home message for colorectal lesions is assess, classify, and then take a call. And important to have all accessories on hand. It might be a simple polypectomy, but you have to anticipate a bleed, a perforation, and you should have all the devices required to help you out. Thank you very much. I hope you enjoyed it.
My sincere thanks to SGI and in particular Dr. Sahu and Dr. Avinash for giving me a chance to speak on US anatomy of the anorectum. This is a very underappreciated area where US has great applicability. Now to begin with, I'll show you the instruments which you can use for anorectal US study. This is a blind rigid rectal probe, and this is a mechanical transducer by Olympus. You also have an electronic transducer from BK Medical. And also what I've not shown is end firing probes for prostate examinations. This is again underutilized instrument. This is a mini probe, UMDP2025R with dual plane reconstruction abilities. Now this is what as endoscopists we most commonly use. This is a flexible radial EUS scope, and all probes from all companies have similar imaging characteristics. And this is a linear probe. This is the to start the rectal evaluation with a linear probe is difficult because the anatomy is still not very well defined. We usually start with a rigid or flexible radial US probe and follow it up with a linear probe if we want to sample a tissue. Now, the comparative studies between the rigid and flexible radial probes are limited and have shown contradictory results for rectal cancer stagings. However, if you look at the performance and imaging capabilities of both of these probes, both of these can be used to examine the iliac lymph nodes at up to 20 to 25 centimeters from the anal verge. So the depth of insertion is possibly more with flexible US probes. And I think as time goes by, we'll be using the flexible instruments more and more often. So first is how do you prepare for the anorectal US examination? If we have to do a limited evaluation, particularly of the anal strictures anal sphincters, then a preparation with enema alone within 1 to 2 hours of the procedure is adequate. Or preferably, we can prepare the bowel with polyethylene glycol, like we do for standard colonoscopy, a split dose regime, 2 liters the night before and 2 liters in the morning within 4 hours of the onset of the preparation. We do a perianal inspection, a digital rectal examination. Patient is usually positioned in the left lateral position, and it is wise to place some pillows underneath the patient and to angle his knee like this so that the position of the torso remains stable throughout the US examination. Patients will often not need sedation for this short procedure. We usually begin with sigmoidoscopy to evaluate the mucosa, any stenotic lesions, and to clean the rectum of stool and any mucus. And as I have mentioned before, we would usually begin with a radial US scope. Now, this is how we start the study. We start by instilling around 100 cc of water to flatten the upper part of the rectum. We can add more water, but if you overfill the rectum with water, it will often mobilize the stool from the proximal rectum and may be counterproductive. We advance the flexible EOS instruments to a depth of around 30 centimeters from the anal verge. And the examination is begun by looking at the normal vascular landmarks. So at 30 centimeters, you are into the sigmoid colon, and you see the bowel loops around, and there are no identifiable structures. So the imaging is done by slow, controlled withdrawal, and the first recognizable landmarks are vascular, and I will just show you those. The probe is centered in the lumen by the use of the big wheel and the small wheel. Now, how do you display the images? Now, this is how a CT scan is done conventionally, and the CT scan shows you the pelvic anatomy as if you are looking from below upwards. So the left is to the right of the screen. Look at the CT scan image of a pelvis, and the marker shows that this is the left side of the screen, this is the right side of the screen, and the spine is here, and anterior part is this. Now, if I show you the radial US imaging, normally in the upper GI tract, you image the patient in the normal orientation. With the normal orientation corresponds to the CT scan imaging, which I have just shown you. And note that the aortic arch in this transthoracic study is depicted to the left side, similar to the CT orientation. And this is a marker which shows you that it is a normal and not a reverse orientation. This is the inverse or the reverse orientation, which is seldom used in the upper GI tract. The image is now flipped, and we don't normally image the patient in the inverse orientation in the upper GI tract. However, when we go into the anorectal imaging, the probe is now coming from below upwards instead of from above down. And if we image in the normal mode, this is the reverse of the CT scan imaging. So now the right is on the right side of the image and the left is on the left side of the image if we image in the normal mode. If we image in the inverse or the reverse orientation, the image flips and now the left is on the right side of the image, and the inverse mode in anorectal EUS perfectly corresponds to the CT scan imaging. However, most of us do not change the EUS orientation, so we continue to image in the normal mode. You can do it in either way, but then just remember that the depiction of lesions and the identification of the lateral walls and the lesions would depend how you have oriented your image when you are doing the anorectal imaging. It is the reverse of the ODAD imaging, and this must be understood. How about the linear US display orientation? This is slightly more difficult to understand. I give you the analogy of a water bottle, of a glass bottle filled with methylene blue. Now, if the probe direction is posteriorly to start with, which means that you are imaging the coccyx or the sacrum to start with, if you rotate to the right, the probe rotates to the right. Now, if the starting probe direction is anteriorly, which means that you have the pelvic organs under focus, which means the probe is directed anteriorly. If you have to go to the right side of the patient, you have to do a left rotation of the, or left or anti-clockwise rotation of the US probe. I hope this concept is understood, because with linear US probe, you just go 360 degrees, and with how to image the left side, the right side, the anterior side, and the posterior side will depend upon understanding this orientation. So have a good look at this. Let's move on now. Now, please remember that the distances from the anal verge. The anal canal is 4 centimeter long. This is the anorectal junction, which is defined by the puborectalis sling. It is just below the tip of the coccyx and corresponds to the apex of the prostate. Then you have the rectum, which is roughly around 12 centimeter long, which takes the rectosigmoid junction at around 15 to 16 centimeters from the anal verge. And this corresponds to sacral third vertebra, S3 vertebra. Now, when you have introduced your EUS probe to say around 25 or 30 centimeters, you are in the sigmoid colon. And here, if you remember your anatomy, and this is very nice to see. So how do you distinguish the sigmoid from the rectum? In the sigmoid, you can see these tinea coli. The tinea coli are the condensed or the bunched up longitudinal muscle on the outer side, outer longitudinal muscle, while the inner circular muscle is concentric. So in the sigmoid, you can see the tinea coli when you collapse the lumen. And as you withdraw to the rectum, the two layers, the inner circular and outer longitudinal, become concentric as you descend down into the rectum. The schematic US representation of the rectal wall is the same as in any part of the GI tract, the standard 5-layer representation. I don't have to go into this. Just remember that the muscularis propria of the rectum at current transducer frequencies is often refinable into inner circular, outer longitudinal, with an inner sheath of hyperechoic fibrous tissue between the two muscle layers. Now, as I have mentioned before, once you are up into 25 and 30 centimeters and you start to withdraw, the first landmark that you see are the vascular landmarks, and these are to be identified to orient yourself. So you can see the cross sections of the aorta and the IVC. This is the aorta. To the left of the image, now I'm imaging in the normal orientation, and the cava on the right side of the screen, and this is the sacral brim or the pelvic brim. And please remember that the aorta divides at the right side, sorry, at the left side of L4 vertebra, and the cava divides on the right side of L5 vertebra. So this is the left common iliac artery, the right common iliac artery, the left common iliac vein, and the right common iliac veins. And as you pull down, you can see the aorta splitting into the two, and the cava, the tributaries of the cava, the common iliac veins converging. As you withdraw, you can see from this, the right-sided iliac vessels are usually seen as you withdraw the vessels. I don't have time to go into the detail, but in general, the artery is closer to the probe, and this stays true regardless of whether you are using a radial probe or a linear probe. So you have the artery which is running closer to the probe. This is the common iliac artery, and the common right iliac vein is away from the probe. Then you see the right common iliac artery splits like a fork into its external and the internal divisions, and you can see further divisions of the internal internal right iliac artery further down. But there are a lot of variations in the iliac artery divisions. How about the peritoneal reflection? This is very important oncologically because the grading of rectal cancer into T4A and T4B will depend whether the peritonealized surface of the rectum has been breached. So T4B rectal cancer is when the rectal cancer breaches into the visceral peritoneum or into the adjacent organ. So endoscopically, we know that the middle rectal fold is the mark of the anterior peritoneal reflection around 7 to 8 centimeters from the anal verge, usually marked by the right side, as you see in this image. In a male patient, the top of the seminal vesicles is the marker for the anterior peritoneal reflection, and in the females, the cervix or the posterior fornix of the vagina marks the peritoneal reflection. Now, how about the pelvic planes and pelvic spaces? Please remember that the lateral wall of the pelvis is formed by the obturator internus. Then you have the levator ani, which divides the subperitoneal pelvis into the supralevator or an infralevator compartment or the perineum. On a heavily T2 weighted MRI, we can define the mesorectal fascia. But in a sufficiently fatty patient, even on US, if you look very carefully, you can make out the mesorectal fascia. And again, this is very important when you are staging a rectal cancer, particularly T3 tumors, when you can actually on US define a threatened CRM like it is done on a MR scan. Now, as you withdraw further, you reach the pelvic organs. The probe is rotated electronically, not by torque, but electronically on the ultrasound console to place the pelvic organs anteriorly. And this is what you see in both males and females. This is a large filled bladder. You will often see the ureter entering the posterolateral surface of the bladder like this. The pubis with its hyperechoic reflection is seen anteriorly. And then you have the seminal vesicles lying posterior-inferior to the bladder. And as you withdraw, you will reach the prostate. So this is a radial US imaging showing the obturator internus forming the pelvic side wall, the bladder anteriorly, the seminal vesicles, the probe in the rectum. This is the area of the Denon-Villiers fascia. And this is a linear probe showing the same thing, the bladder, the seminal vesicles, the prostate, and the pubis. The prostate has a central zone and a peripheral zone. Again, you can do a detailed prostatic examination. Time does not permit me to tell you that. This is the obturator internus. This is the ischial bone with its reflection. And then as you trace the prostatic urethra down, you see the bulbar urethra going anteriorly with the corpus spongiosum on either side. And this is a schematic representation of the levator ani or the pelvic floor, taking off from the sheath of the obturator internus and the obturator internus, which is forming the side wall of the pelvis, also seen here on a EUS examination. In the females, obviously, you see the uterus, which has an oblique lie in most patients behind the bladder and between the rectum. And also, as you withdraw down, you see the cervix, sometimes with cysts, and then the vagina with the Denon-Villiers fascia or the rectovaginal fascia in between, with a linear airstripe in between. With a linear probe directed anteriorly, you can again make out the vagina. It is seen very thin behind the bladder and the pelvic floor. I shall just show you better in the next image. So here is again another patient with a linear probe evaluation of the female pelvic organs. You have the bladder, you have the female urethra, you have the uterus, which can have a very variable appearance with a lot of pathologies. You have the cervix, and then you have this air stripe showing you the vagina, and this is the Denon-Villiers fascia. And then you have the pubis and the puborectalis and the pelvic lateral wall and muscles. Now, coming down from the rectum to the anorectal junction, the anorectal junction, please remember, is not visible endoscopically. This is the dentate line. This is the anorectal line or the line of Hermann and Desfosses. This is the anal transitional zone under which you have the hemorrhoids. And this is the anorectal ring around a centimeter or above. Endoscopically, it is a virtual landmark. On PR examination, it is palpable posteriorly and laterally as a ledge of puborectalis. And on US, the anorectal junction can be well defined as the upper border of the puborectalis. So this is the puborectalis sling. And this is an inverted image of the pelvis where you see that this is the puborectalis sling. So puborectalis sling, puborectalis sling. And this is how a puborectalis sling looks. This shows you the anatomy of the anal canal. Now, layer 1 is the slightly echogenic inner mucosa and submucosa layer. This is the internal anal sphincter. This star is on the conjoint longitudinal ligament. And 3, the hyperechoic layer is the striated muscle or the external sphincter. Now, when you are doing a EUS imaging of the anal canal with a flexible probe, please remember that the length of the probe itself is 1 centimeter. And I have placed a ruler here which shows you that for the Olympus probe, the distance of the optics to the tip is around 2.5 centimeters, which means that the optics may be out of the anal verge when imaging the middle to lower anal canal. It also has a flexible bending section, so it is very important to avoid tangential imaging. So how do you image? You hold the scope is gripped with one hand against the anus. So your grip now is right against the anal verge to stabilize the instrument within the anal canal so that the patient doesn't push it out and you remain in a stable position. This is what I had described. Anal canal on EUS shows you a 4-layer structure. The mucosa and submucosa cannot be resolved separately. We call it a mucosa-submucosa complex. Unlike what is written in the textbooks, we can normally see, at least I can make out very well the hemorrhoids in the mucosa-submucosa complex. You have the internal anal sphincters. And if there are hemorrhoids, you see the hemorrhoidal vessels penetrating the muscular layer. This mixed echogenic layer is the conjoint ligament, which is an extension of the longitudinal ligament of the rectum. This is the external anal sphincter. Now, when we image the anal canal, we image it at 3 stations. One is the high station, where you have the puborectalis and the deep part of the external anal sphincter. So the ring of EAS is incomplete anteriorly, and this is the area of the perineal body. So you have a complete hypoechoic ring of the internal sphincter, the puborectalis, but the striated muscle may be incomplete anteriorly, more so in females. The middle anal canal is defined by the superficial part of the external sphincter. So you have the complete IAS, complete EAS, perineal body anteriorly, and the anococcygeal ligament posteriorly. That is the mid-anal canal. When you talk of the lower anal canal, the internal anal sphincter finishes, and the external anal sphincter, as you see in this image, extends for about a centimeter or so below the end of the internal sphincter. So you only see the whitish striated muscle, and this is the lower third of the anal canal. We measure the sphincter dimensions at the mid-anal canal level at the 3 o'clock and at the 9 o'clock level. Internal anal sphincter is normally 2 to 4 millimeters in diameter, and it gets thicker with age. But at any age, more than 4 millimeter is abnormal and is one of the contributory causes of a pelvic outlet obstruction. External anal sphincter is 5 to 10 millimeter and is often overestimated by US, and like any other skeletal muscle in the body, it becomes thinner with age. So this is just to show you the anal sphincters with a linear probe. This is the puborectalis. Here is the inner circular muscle, which expands to form the internal anal sphincter. outer longitudinal muscle, which extends as the median conjoint ligament. This is the external sphincter. And if I can pause this, see that the internal sphincter ends before the external sphincter. So this is the external sphincter. This is the internal sphincter with a linear probe. This is a medial conjoint ligament which thins out as you reach the lower part of the anal canal. So you can trace it roughly halfway down the internal sphincter, and the external sphincter sort of centimeter below the internal sphincter. Now, what about the perineal body measurement? It is seen below the levator at mid-anal canal level, as I have mentioned. It is not seen as a distinct structure on US, but it separates the anal canal from the membranous urethra in males and lower vagina in females. And how do you measure it? One gloved finger in the vagina and the probe in the rectum. So the measurement is from the reflection of the gloved finger to the inner margin of the internal anal sphincter, and less than 10 millimeter is a attenuated perineal body. That is the definition. Anococcygeal raphe is also seen in the mid-anal canal as a triangular hypoechoic structure posteriorly, and the importance is that this should not be taken as a midline posterior sphincter defect, should not be confused with it. And I think I have managed to cover most of the anorectal anatomy with US, although in a rushed fashion. I shall be happy to initiate any discussion. Thank you.
Dr. Yami, am I audible? Dr. Reddy?
Yes, sir.
Dr. Reddy, am I audible?
Yeah, yes, sir. Yes, sir.
Just one apology. The cursor which was recorded had a lag actually in the video.
Yes, yes, sir.
So
Definitely.
just to sound the audience that the cursor was not truly recorded. So I think in the Zoom media, the video
Yes.
and the cursor, there was a lag. So the cursor was not truly moving on the lesions as I was describing it verbally. So my apologies for that. I hope you understood the topic, US anatomy of anorectum.
Thank you, sir, for excellent demonstration of the various anatomical structure. And sir, one thing, one query for you, that is regarding the preparation, depending on the operator, they sometimes do enema or colonoscopy preparation because the fecal matter can produce artifacts while doing the performing the procedure. And which one you prefer? Is there any particular situation colonoscopy, standard colonoscopy preparation is preferred over the enema alone?
In general, if I have to go into the rectum, I would prefer a PEG enema, a PEG preparation, a full split dose PEG preparation, because even a limited amount of stool, you can never predict how much stool a patient will have in the rectum once you go in. So if you are going to do a rectal evaluation or a sigmoid evaluation, then it has to be a split dose PEG preparation like a colonoscopy. If I have to just do a sphincteric evaluation, then anal canal will normally not have any stool. It is very simple. Then I just reduce the stool burden with an enema, ask the patient to evacuate just before the procedure, and then for anal evaluation, that itself is sufficient. Sometimes even unprepared evaluation is okay for the anal canal.
And one more question regarding the sedation, you prefer for all, sir, or any preference, sedation?
No, actually, there is not much requirement for sedation, even if you go up high in the rectum. We are privileged that we do all procedures with propofol, but that is a luxury, not something essential.
Yes.
It is just to give some patient some amnesia, some dignity, and maybe just make him or her more comfortable for the procedure, and more of the patient comfort measure rather than any necessity for the examination per se. Since many patients are embarrassed, and well, it is an anorectal examination, never a comfortable discussion or a procedure for the patient. So more for the patient embarrassment or comfort is sedation required, not for the procedure per se.
Regarding the indications, even though it has complementary role in assessing the rectal cancer staging and thing. Generally, we most of the center, even though we practice routinely, we rarely get the cases for the assessing the real assessment of the thing. And only what I frequently performed is one is a rectal abscess. I drained it. That is one thing, and a few metastatic deposits in the Douglas pouch, and they ask for the FNAC, and those are the two things therapeutically I performed. But what are the common indications you get because you work at a high volume center? and what are the common indications you get?
No, we don't make a distinction between upper and lower. So there are many indications for upper, many indications for lower.
Low.
The lower
But
part
lower.
is just being underutilized. So
Yes.
right from anal sphincter evaluation, pelvic outlet obstruction,
Yes.
pelvic pain, puborectalis dysenergia, and obstructed defecation, sphincter defects, post-surgical sphincter repair from the anal canal.
Yes.
Also perianal fistulas, the abscesses, perianal abscesses, a definition of the abscess, then all pathologies of all submucosal lesions of the rectum, if indicated, obviously. Rectal cancer staging, particularly low rectal cancer, where US has some superiority over an MRI.
Yes. Yes.
And in stenotic lesion, MRI is more superior to
Superior.
possibly a non-passaged
Yes.
US
You can't
evaluation.
evaluate completely.
And also the pelvic gynecological pathologies like suspected endometriosis,
Yes.
certain other select pathologies, metastatic deposits in the pouch of Douglas,
Yes.
lymph nodes in the lower pelvis. You can go up right till the aortic bifurcation. So certain lymph nodes are better evaluated from below. The rectal wall is easy to puncture. And then infectious complications should not deter you from puncturing across.
Okay.
And prostatic evaluation, although I have not covered that, the lower ureteric stones at the pelvic-ureteric junctions can be very well seen with US. Bladder pathology, so now you are encroaching on the urological part. My only disappointment is that with the US, you cannot give a adequate histological confirmation of prostatic cancer as is the requirement by the urologist. But still evaluation of many different odd pathologies of the prostate and the prostatic urethra is a very wide field, actually underutilized. And then the lateral, the pelvic compartments and rectal cancer staging, particularly the sub refinement of T3 categories is so this and many more I would have forgotten.
One thing, sir, while particularly while draining the rectal abscess and while choosing the cases, one the distance away from the rectal wall and the multiloculated thing, and what are the very ideal cases to select for drainage, per rectal drainage of the pelvic abscess?
So per rectal drainage of abscess is very simple. Unlike a pancreatic fluid collection, there is no ductal communication with anything. So you don't need to create big holes and the stents don't need much dwell time. Once you have evacuated the contents, they will usually not refill. So that is principle number one. So people have placed lamps and other things, but that is not essential. Rectal, perirectal collections are totally different from a pancreatic collections where there is a disrupted duct feeding into the collection. The most important thing in draining abscesses or collections in the pelvis is to make sure you don't perforate, which means that you may as well open the peritoneum in trying to drain a non-loculated non-collection. So one has to be very, very cautious. These collections look very tempting, but they may be free in the peritoneum, not localized. You open them up wide, and then you have created a perforation and kept it open by inserting a stent. So please don't do that. The choice of the abscess drainage has to be very strict. Infraperitoneal loculated inside an organ or very well defined. A percutaneous catheter drained from outside versus a lumen of the bowel being opened from inside are totally different things. They should never be equated. So in a non-localized collection, the radiologist may insert a percutaneous catheter under sterile conditions, drain it outside, that is acceptable. But you open a non-localized peritoneal collection, you have created a perforation. So
Yes.
the patient selection and the principle should be kept in mind. It's all a matter of common sense.
As a peritoneum is covered in the upper two-thirds of rectum and the lower third is relatively free. And you mean to say the collections below that level, above intact peritoneum is needed, or any well-defined collection, even if it has extension into the peritoneal cavity, is okay to drain?
No, so the point remains the same. You can perforate free into the peritoneum or you can perforate free below the peritoneum. Obviously, the damage done is more if you are above, but then I would not want to open up a non-defined collection or a collection outside any defined organ on either side of the peritoneum. So you will possibly get away if you do it below the peritoneum because it is still a confined space by
Yes.
virtue of the bony pelvis.
Okay. It should be
But in general,
well
think
calculated.
what you are doing.
Okay. Thank you, sir. Regarding to ma'am, I have one query to ma'am. Ma'am, while performing after performing ESD and EMR, you sprayed the collagen spray, and
Yes, sir.
from which company you used it, ma'am, and which product?
This is Hemoseal spray by Shaili. It's
Shelly.
an invention by Dr. V.G. Mohan Prasad actually.
Okay.
So he uses it mainly to heal ulcers and also to for bleeding lesions. Let's say there's a malignancy and it's if you are just giving palliative care and the patient has a lot of bleeding, spraying collagen helps. And if we have like uh, I'm talking about other things, like let's say there is an ulcer bleed and then there is so much of bleed that we cannot visualize. Initial we can spray collagen and wait for it to get controlled. So collagen is a natural component and activates many parts of the coagulation cascade. So it helps really and also helps in healing. So we usually use it for all lesions to promote healing. You could see in that one patient, actually the video didn't play, but post resection, the first patient, post resection, the patient had a 2/3 involvement of the rectal circumference. And in spite of that, after removal, you can see the base, it's so clean. It also helps with pain management. Sometimes, they don't have any pain at all.
I request panelists and chairpersons to have any queries to our presenters. One last question to Vikram sir. Sir, regarding the rectal varices, ma'am showed EVL banding that generally we do. And what is any your experience with coil embolization with in perirectal varices, portal hypertension with low RGI bleed? Any experience?
Yes, so unlike the upper, where we are reasonably good in practice with the direct endoscopic injection of varices, in the rectum, I have moved. I would like to do a US guided injection in most rectal varices. Coil deployment is very difficult because you need micronester coils. The perforators are around 4 millimeter, 3 millimeters, 5 at the maximum. So you need very small coils. And then, well, if you put a coil, the perforator is gone, but then very often the results are not very good. So the good thing about rectal varices is that unlike a gastric varices, the perforators, the inflow perforators are easy to define. In practice, you find one perforator, two perforator, max three perforators, but usually one dominant perforator which is coming in. You can target the inflow perforator with confidence and see the injected flowing down. I use mostly US guided sclerosant injection and something called foam sclerosant. That is my way of doing it, but then I have to publish it because I am afraid of glue. It's a small channel injected, and then I am afraid of the glue spilling out. So you can puncture it with a 19 or a 22 G needle and do a sclerotherapy into the perforator, and the inflow will take it down into the downstream rectal varices. But honestly, the idea is to occlude it. So you can inject a thrombin slurry. We have done that. You can inject a micronester coil. You can inject glue or a combination of these. Everything, but he has done everything. There are only 5 or 6 case reports,
Yes,
case
sir.
series available in the literature. This is uncharted territory. But we do it. We do it with the US guided injection now, most of the cases. And bending, I don't do much bending in the rectal varices, although they are very good. But if bending is to be done, they are to be done at the topmost part of the varix, not at the lowermost, unlike what has been propagated by the paper by Dr. Patrick Kamath, that you bend the downstream part. No, perforators are from above. So you bend the topmost part of the varix first, always.
We have, with the permission of the chair, we have seen the varices, like even the distal varices disappearing once you just go and catch the proximal varix. So beautifully, it's so gratifying and it's so simple. Even
Yes.
duodenal varices, the best thing to do is to do an endoloop or do band ligation. And about Sir's question on collagen, which was my invention, is 2011. So now it's gone for patenting also. So we've used in two situations. One is the bleeds, the other one is for healing. So after endoscopic mucosal resection, or like the one video Madhura was trying to show was 7.5 centimeter lateral spreading adenoma with 2 spots of carcinoma in situ, which is circumferential in the rectum. That's why we took 8 hours to dissect. I just wanted to test my skill whether I can withstand that sort of a procedure. So I did it overnight, and then again the next morning I posted. So once I dissected the whole area, circumferential 7.5 centimeters, and then like I sprayed collagen. Absolutely no pain, nothing. The patient, that was my one of my close friend who was a doctor, his own sister. Now on follow up for 3 years, absolutely no further recurrence. So the collagen, it's just like I had another lady with the esophageal just 2.5 centimeters, which I dissected. This was about 5, 6 years ago, and then sprayed collagen on top. And then next, within 6 hours, the patient could drink a hot bone meat she could take without any pain. So it just forms a barrier, it protects. And also collagen, generally, if there is a mucosal abrasion, the collagen comes into play only on day 3 to 5. Whereas here, we are doing it in hour zero. So we just bring in collagen in hour zero because it yet has to wait for the fibroblasts and macrophages to come in, that is day 3 to 5. So here we start at hour zero. So it just starts forming a matrix over which the epithelialization can happen, platelets can adhere. So it forms a beautiful. I'm done, sir. Thank you.
Thank you. Any other queries or?
Yeah, I can ask one. Yeah, in the rectal polypectomies and all, even in the smaller ones, like more than 10 millimeters, they're doing. And when after doing polypectomy, if you take biopsies from the edges and all, it's been shown like almost 10% have some residual adenoma left behind. So, what particular tricks do you suggest to avoid this?
You're talking about adenomas where your sessile
Sessile
lesions,
adenomas. Yeah.
and even though you're removed from the base, so one
Yeah,
is
there are many studies which show that even after good care and all, the edges still show some 10% of them show residual disease.
so what we do is we keep them under surveillance. What Dr. VGM was telling, that patient with a large tuberculous adenoma, we had her under 3 months, 6 months surveillance, and we kept checking. And NBI examination, that is what I wanted to show. Actually, the NBI examination, again, we checked and we got we biopsied, and there was still a little portion of tissue there. So we resected that once more. So my suggestion is to have a good surveillance, but would you like to discuss any
No,
techniques?
actually, I think what Madhura Srinivas was asking about, post dissection,
Immediately
if you
after.
find some residual tumor tissue, what do you do? Many of the Westerners would do just APC. That is the simplest and the easiest. So
We
otherwise,
also
you can
did
use the
APC on all the
yeah. You
remaining
can
tissue for the previous
also
lesion.
you can.
My doubt is like, as in Barrett's esophagus, can it lead to some buried this one like syndrome, like, and cause recurrence later? That's the if you use APC.
If the dissection is not proper and if you're left residual tissue, yes, by burning APC. If it is deep seated, then it can just get buried in. On top, the squamous epithelium will grow, but underneath the tissue will remain. So I think
Are you
the tip
talking
is
about the
proper.
edges, sir, or below?
Yeah,
Are you talking
edges,
about the
edges.
edges or below? Because
Yeah, especially
the depth. I think you mean the depth, sir.
no, you. See, no, I'm not lateral.
Lateral
Lateral
edges.
R0 is this one. Yeah.
Lateral edges. Okay.
Yeah.
The
A good
edges.
edge.
So that is what. So you need to have proper assessment prior to start dissecting. You just need a good NBI. Just zoom, have a look at the margins, and then mark them properly, at least a centimeter away from the edge, so that you don't miss out the lesion. So it's always better to mark it properly and start dissecting rather than miss out some edge. I think I should congratulate Vikram for a fantastic lecture on EUS. It was a beautiful anatomy class for us. I was just wondering now, many units have given up using radial scopes. So that is why the linear scopes are very important. In our unit, we use both, but we are very bad at anorectal EUS. We don't deploy much at all. So I think probably you should come and train us once to do all these EUS, anorectal EUS.
No, thank you, sir. Coming from you, I am humbled, and
Sir.
thanks again, sir. I mean, I learn from you. I cannot teach you. Thank you, sir.
Oh, we always learn from all of you now.
Sir. But we use a lot of radial EUS. So we use radial EUS, we use mini probes, we use IDUS, we use linear probes, we use transabdominal probes. So, and I mean, and I don't think we should be condemning radial either in the upper or in the lower tract. It is still in India, we still have limited scopes. We are not that rich or that resource affluent as in the Western countries, because you use linear US probe, just keep on gluing, you'll lose your scopes in a matter of, or only directed at interventions, you'll soon end up without your scopes. A electronic radial US scope can still be the workhorse of the department, restricting a linear US scope to FNA and targeted intervention.
Exactly.
So it is still a very useful modality, both in the upper as well as in the lower. We are very fond of all the US modalities.
And especially when there is a small lesion, like a tiny polypoid lesion, I find that mini probe is the best. You just fill in water and keep the mini probe. All the layers are so beautifully defined. You can just very easily make out from which layer it arises. We always
Absolutely,
deploy a
sir.
mini probe before we go in for EST.
The more varied modalities of US that a person uses, the better his skills and cognitive abilities become. So you restrict yourself to one plane of imaging, and then I don't think the cognitive part is going to extend beyond a certain limit. So you see the sphincters with radial, with linear, three-dimensional reconstruction with the probes, and then your understanding possibly deepens. Ditto with even a bile duct in the upper tract. You see it from the inside with IDUS, from the outside with the US, with the linear, with radial. Doing one thing improves you in the other thing also. So I don't think, at least in US, which is mainly a cognitive modality, more of learning rather than just the hand movement, because we are not doing anything, we're sitting there and watching. Using multiple modalities of US is absolutely essential in my mind.
So do you prefer
Sir, how often do you use EUS in defecatory disorders to assess? How often do you use in your clinical practice?
I am
And
sitting in a
what would
liver
be the
hospital. I do get some referrals, but I'm sorry, this modality is very underutilized for me. I wish I could do it more often. I'm trying to get the gynae people from other hospitals to send those to me. We do have some run-ins, but yes, very underutilized.
So do you prefer the rigid scope or the flexible scope? For
Flexible
the
scope.
rectal?
Flexible scope. I use the Olympus rigid also. We got it. I was very fond of it. I got it. But I'm no longer in Fortis. In my previous hospital, I had it. Now I'm only with a flexible probe.
Yeah, I find it particularly difficult when I'm using in upper part of the rectum, where you cannot completely fill the rectum with water.
I agree. So right
Like,
now, if you have the choice of a mechanical rotating rigid probe, it offers you no advantage over a flexible probe. Flexible probe is far superior because uh, it gives you much more this thing. But if you have a electronic rigid linear probe from some manufacturers, it gives you the option of elastography to evaluate the sphincters, 3D reconstruction. All these are by BK Medical paired with Hitachi. Then obviously you get other advantages over the current radial US scopes, which do not offer you the same. So the 3D reconstruction, 3D work in the anorectum, the rigid probe is more rigid. You are not dependent on your hand for slow withdrawal. And for elastography, these are the only places where rigid probes by the BK Medical may give you, these are the electronic radials may give you some advantage. But practically, a flexible radial probe is very good.
Actually, as we are overshooting the time, and I must thank Dr. Vikram Bhatia and Dr. Madhura Prasad for their excellent presentations and giving their insight into the subject. Thank you, sir. Thank you, ma'am. And I thank you all chairpersons and panelists for their inputs. Uh, Thank you.
Thank you.
Hello, hello. 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 Are we audible?
Yeah, ma'am.
Okay.
Yes, yes.
Yes, ma'am.
And we will have the slides display, and then at the end we'll have the presentation. Yes.
Sorry, ma'am.
We'll first be playing the recording sessions, and then we will have the discussion with the
Yes,
panelists
ma'am.
and everything. Yes. All right. Good afternoon, everybody.
Good afternoon, ma'am. We'll be starting with your video at 12:45.
Yeah.
And there is a second video by Dr. Rupa Banerjee after that. And then we'll have the panel discussion.
Okay. So has Dr. Rupa joined? Because I can't see her anywhere.
Right. We'll have to find out 1 second.
Ma'am, I've conveyed to Rupa, ma'am. She'll be joining, ma'am. In another 2-3 minutes, ma'am will be joining.
Okay. All right.
Yeah, thank you.
Thanks.
So very good afternoon to everyone. This is an IBD session in the Endocon 2021. We'll have two talks. The first talk is by Dr. Anshu Srivastav on pediatric IBD in India, and the second one by Dr. Rupa Banerjee on endoscopy in IBD. Following this, we'll have a short panel discussion. I request the moderators to play the first video by Dr. Anshu Srivastav.
Good afternoon, everybody, and welcome to the midterm Endocon. I'm Dr. Anshu Shrivastava from the Department of Pediatric Gastroenterology at SGPGI Lucknow. And at first, I would like to thank the organizers for giving me this opportunity to speak on a very relevant topic which is close to my heart of pediatric IBD in India. In the Western population, pediatric IBD accounts for about 15 to 25% of all IBD. And although we don't have any population-based study on children from India, but there's recent data which suggests that roughly around 7 to 8% of all IBD is diagnosed in the children. Keeping in with the trend of a global rise of pediatric IBD overall, which is more for Crohn's disease as compared to ulcerative colitis, even at our own hospital at SGPGI, we have seen that the number of cases per year has increased from 3 to roughly about 20 in the last 12 or 14 years. Similarly, the multi-centric data which we have just collected on pediatric IBD from the country has also shown that there is an increase in the number of cases in the last decade. And keeping with that are the numerous publications which are coming in the last 5 to 10 years. Some of them are listed here, some of them are not there because of lack of time. As you see in this pie chart, that in the Indian data of 325 children with inflammatory bowel disease, boys were 55%, roughly 2/3 or 65% were Crohn's, and 28% were ulcerative colitis. In the north, ulcerative colitis is more common than Crohn's, whereas in the south, it's Crohn's disease which is more common. And this is similar to the Western data, except for this fact that only 7 to 9% of our patients have a family history of IBD, in contrast to the West, where it is more common and seen in roughly about 20%. Indeterminate colitis, or what we call as IBDU, is a very important group because children have IBDU more often than the adults, as shown from the data from Kerala, 15% versus 2%. They mostly have pancolitis, and it is very essential that we evaluate the entire bowel with an upper GI study, a lower GI colonoscopy, and a small bowel evaluation for the correct diagnosis. And as you can see from this Indian data, that IBDU is seen in roughly about 1 in 4 patients in those who are less than 6 years of age. Whereas as the child becomes older, the chances of having IBDU go down. And it is important to have a correct diagnosis because if you falsely label them as ulcerative colitis and subject them to a surgery, they have a higher risk of pouchitis and pouch complication post-surgery. Pediatric IBD is not a uniform group. And once the child is diagnosed at less than 10 years of age, we call it as early onset IBD. If it is diagnosed at less than 6 years, it's very early onset, less than 2 years infantile, and in the first 28 days as neonatal IBD. And there are 3 studies which have been published in this year in 2020. The SGPGI experience, the multicentric data, which is showing all in red stars, which has been collected from the centers in the north, south, east, and west of the country, and the data from AIG Hyderabad. And as you can see, that 7.5 to 19% of our children have very early onset IBD in comparison to the Western population where it is 6 to 15%. And the most common age of diagnosis is 10 to 17 years. The problem is that very often children who have isolated abdominal pain and have presenting to you with the OPD with just this as a symptom often have a maximum delay because no one suspects Crohn's disease. And it has been shown that from the AIG data that roughly 6 months, more than 6 months of delay is seen in 40% of VO IBD and 80% of late onset or the older children who come to with IBD. In contrast, in the multicentric data, it was about 4 months delay for ulcerative colitis and 6 months for Crohn's disease. Why do we have to make an effort for an early diagnosis is because a recent study has shown that if a delay of diagnosis is more than 9 months, then these children have a 2.5 times higher risk of presenting to you with stricturing or internal fistula. And they also have a reduced height. So the earlier we diagnose, the better these children tend to perform. And for this, we have the IBD refer criteria, which again suggests that if there is a child with bloody diarrhea or diarrhea without blood for more than 1 month or recurrent perianal abscess or fistula, these children should be referred to a pediatric gastroenterologist. However, if you don't have these, but you have 2 or more criteria of group 2, which would a typical setting would be an abdominal pain with growth failure or with a higher ESR, you should suspect that there could be a possibility of underlying Crohn's disease, and these children should also be referred earlier to the gastroenterologist. In our experience, Crohn's disease, the most common form in the Indian children is ileocolonic, and roughly about 73% of these children have ileocolonic, whereas the upper GI involvement is seen anywhere from 6 to 18%. And as you can see, it is similar to the data from the EuroKids registry. When we look at the phenotype of the Crohn's disease, 80% of our patients have the inflammatory phenotype, around 10% have the stricturing, and around 10% have the penetrating. Whereas perianal disease is present in 10 to 20%, and nearly 20% of our children have growth failure. Again, similar to the Western data. In ulcerative colitis, most often we see pancolitis, which is seen in 60 to 70% of the children, and nearly a third of the children have had severe disease one time or the other after being diagnosed as UC. Amongst the extraintestinal manifestations, what we found that in our data which we collected from various centers, nearly a third of our IBD had an extraintestinal manifestation, and of which oral ulcers, arthralgia were the most common, more often seen in Crohn's disease as compared to ulcerative colitis, and so was erythema nodosum. While in the Western data, it has been very clearly shown that angstpon and erythema nodosum were more common in Crohn's, whereas primary sclerosing cholangitis was more often seen in ulcerative colitis. Now, going on to this very important group of very early onset IBD, which is when we diagnose it in less than 6 years of age. Why do we need to recognize this? Is because in roughly about 5 to 20% of these patients, they may be having a monogenic disorder or an immunodeficiency, which is presenting with an IBD-like presentation. And it is important to recognize them because they are prone for specific complications as well as the treatment differs. And in some of these conditions, a bone marrow transplant might be curative. And on the screen, you can see that there is a long list, 50 of them, which have been described to present as very early onset IBD. Some of the important ones being the IL-10 deficiency, the X-linked inhibitor of apoptosis protein deficiency, Viscott-Aldrich syndrome, IPEX syndrome, and various other syndromes, chronic granulomatous disease, which have been diagnosed and they present like a VO IBD. Now let's go to cases. The first case was a female infant who started having blood and mucus in stools from 4 months of age. This child was admitted elsewhere and was started on antibiotics, steroids, and soya feeds, but didn't respond. And then she was put on extensively hydrolyzed formula and an amino acid formula, keeping in mind the diagnosis of cow's milk protein allergy. At 9 months of age, this child passes stools through the vaginal orifice was noticed, and this is the time when she was brought to us. There was no history of sibling death, no consanguinity, no family history of IBD or immunodeficiency. When the child came to us, abdominal examination did not reveal anything. On perianal inspection, there was a rash, and as you can see here, that there was a fistulous opening and there was a rectovaginal fistula also. This child had raised platelet count, raised CRP and ESR, and we went on to evaluate this patient. And he showed that the colonoscopy, this child had deep ulcers in the colon, there was pancolitis. The histopathology was just showing inflammation and crypt distortion. It was negative for CMV and tuberculosis. Upper GI was normal and the small bowel was normal. We worked further for immunodeficiency, the immunoglobulin profile, DHR test for chronic granulomatous and lymphocyte subset analysis, all was normal. This child was treated with biologicals also and did not respond. So what we had was a child who had infantile onset of colitis with failure to thrive, perianal disease, fistulizing disease, rectovaginal fistula, no response to immunosuppression, including infliximab. And this child, we had to resort to a terminal ileostomy as a diversion procedure because this child was not responding to any treatment and was going down the hill. So we got the genetic sequencing done and it showed that this child had a homozygous mutation in the IL-10 receptor and was advised for hematopoietic stem cell transplantation. As we all know that IL-10 is an anti-inflammatory cytokine and when this pathway is functioning normally, it inhibits the lipopolysaccharide mediated release of TNF-alpha through the JAK1 and tyrosine kinase 2 receptor pathway, and therefore it keeps the inflammation under check. Once we have a defect in the IL-10, there is uncontrolled inflammation and the child presents to you with VO-IBD. And the most often criteria or the most often symptoms with which these children present are, they often have a present in the first few months of life. They have severe perianal disease, enterocutaneous or rectovaginal fistulae, chronic folliculitis, arthritis, recurrent respiratory diseases, and failure to thrive. They have a poor response to conventional immunosuppression, as was seen in our case, and they respond very well to hematopoietic stem cell transplantation. And as you can see, that these are 5 studies, and anywhere from 8 to almost about 30% of these children, depending upon the selection criteria, had these IL-10 mutations. Now going on to the second patient, this was a 3-year-old male when he came to us. This child again was having colitis from first month of age. He was having fever on and off and had VP eczematous skin rash for about a year. And there was failure to thrive. There was no consanguinity, no suggestive family history of IBD. This child had mild pallor, had an eczematous skin rash, and there was excoriation of the skin and the ear. He had a 2 centimeter soft palpable liver. The spleen was not palpable. We went on to evaluate this child. He had anemia, he had thrombocytopenia, and we found that his ESR was raised and CRP was mildly raised. When we went ahead and did the colonoscopy, we found that from the rectum to the cecum, there were discrete aphthous ulcers and the terminal ileum was normal. Upper GI study and CT enterography was also normal. Histopathologies just showed inflammation with plasma cells and neutrophils. The immunoglobulin profile, IgG, A, and M were normal, whereas IgE was raised in this child. So what we had was a 3-year-old child who had colitis, sepsis, eczematous skin rash, thrombocytopenia, hepatomegaly, and failure to thrive. And because of this combination of thrombocytopenia, eczema, and colitis, we thought of Wiskott-Aldrich syndrome. He was treated with emollients, topical steroids, and during his stay, the skin lesion improved, but colitis persisted. When we investigated, we found that there was a homozygous single base pair deletion in the Wiskott-Aldrich syndrome gene. He was advised bone marrow transplant, which he underwent, and the child is doing well. So Wiskott-Aldrich syndrome is a unique condition which is X-linked and therefore it presents in boys, and it is characterized by a typical triad of thrombocytopenia along with small size platelets, eczema and recurrent infections, which could be pneumonias or ear infection, and the colitis-like presentation along with eczema often simulates, and these patients are often misdiagnosed as milk allergy. They have a bleeding tendency, which may present as hematemesis, purpura, hematuria. They have lymphadenopathy, hepatosplenomegaly, and presence of eosinophilia, and the boy because of the X-linked nature towards Wiskott-Aldrich syndrome. And these patients, they respond very well to a bone marrow transplantation. So after having seen these two cases, the question comes as when do we suspect a monogenic disorder when we have a child who has symptoms of IBD in less than 6 years of age? If it's an early onset of disease, especially less than 2 years, if there is history of parental consanguinity, or there is a positive family history, or you find that there are multiple boys who are affected in the family, if there is early perianal and fistulizing disease, if you find that the patient is not responding to the conventional immunosuppressives and biologicals, if the child is having extraintestinal manifestations in the form of arthritis, skin lesions, albinism, or woolly hair, if there is associated autoimmunity like diabetes and thyroiditis, where we suspect an IPEC syndrome, if there are recurrent infections, especially with atypical organisms, which point towards the presence of an immune deficiency, if there are lymphoid abnormalities like a splenomegaly or a lymph nodes enlargement and abscesses, or if you find on histology that there's apoptosis, which points again towards IPEC syndrome, and autoimmune enteropathy, if there's lack of plasma cells, which suggest presence of CVID, if there are pigment-laden macrophages, which are seen in chronic granulomatous disease, if these pointers are present and the child has a disease onset early on, then we should suspect monogenic disorders. Now, looking at how was the very early onset IBD in our experience different from the older IBD. And this is basically the two studies, one the multicentric study and the second the data from AIG. As you can see that IBD-U was more common in the very early onset IBD, 30% versus 1.6%. Even the patients who were diagnosed with Crohn's disease more often had an isolated colonic disease. And this makes differentiation between UC and Crohn's a little different in this age group. The disease was more severe. They had a lower weight. They more often had a bleeding per rectum, and pain abdomen was less frequently seen in the very early onset IBD in an Indian subset of patients. Whereas perianal disease, extraintestinal manifestations, and positive family history were equally common in both the very early onset and the later onset disease. Therefore, whenever we have a child with very early onset IBD, apart from the routine evaluation, a basic immunological workup with immunoglobulin profile, complete hemogram platelet size, and an advanced immunology looking for CHD, chronic granulomatous disease, for oxidative burst, lymphocyte subset, and special staining for these immunodeficiency disorders, and then at the end a genetic sequencing so that we can pick up the exact disease which is causing this manifestation is absolutely mandatory. And here the help of an immunologist is very useful. When we look at our data of treatment, how our children were treated in the multicentric study, you can see that steroids and aminosalicylates were most often used. Azathioprine and methotrexate were used more often, roughly to the tune of 40 to 50% of the patients, but biologics were used very infrequently to the tune of about 5% at diagnosis. So what our data showed to us that for Crohn's disease patient, we hardly used nutrition as a treatment paradigm, and nearly 10 to 18% of our children had received anti-tubercular therapy prior to being diagnosed as Crohn's disease and receiving the treatment for Crohn's disease, whereas biologics and surgery along with enteronutrition were underutilized. This highlights the importance of using early biologic therapy, because whenever we use early biologics, this is the only group of medicines which have been shown that they can prevent the growth failure, and it has also been shown that early use of biologics may decrease the penetrating complications in Crohn's disease patients. Therefore, as per the recommendation of 2020, amongst the Crohn's disease patients, if they are presenting to you with growth delay, if they are presenting with extensive disease, that is panenteric disease, deep colonic ulcers, or perianal disease, this is defined as a high-risk group, and these patients should be considered for an upfront biologics. Now, nutritional therapy is coming as a very relevant therapy because children are often having growth failure, and repeated courses of steroids for treatment of inflammatory bowel disease often complicates this issue. Therefore, initially for many years across European countries, exclusive enteral nutrition was being used as a modality to induce remission in patients with mild to moderate Crohn's disease. And this was seen in it was successful in about 70 to 80% of patients, which was equally good as steroids, but it led to mucosal healing in 74% of patients, in contrast to 33% with steroids. But the problem was that in this therapy, the child is asked to have only that nutrition, only that formula, and he's not allowed to eat anything else. So you pick up a formula which is a polymeric formula, and the child has to drink that, or an NG is placed and the child is given that formula, and only that formula for the 6 to 8 weeks that he's getting the exclusive enteral nutrition. And therefore, there was a problem of compliance and acceptability. So recently, in the 2020 and the 2019, we have seen that Crohn's disease exclusion diet has come up, which is basically a recognition that in our diet, there are certain items or certain food items which are pro-inflammatory and have an inflammatory phenotype, whereas there are certain other food items which are anti-inflammatory. And I can't go into the detail, but there's a lots of work being done in this in the last couple of years. And a recent study has shown that if you gave the patients a Crohn's disease exclusion diet plus 50% of the calories from the formula, in comparison to a child who's getting only exclusive enteral nutrition, that is only the formula. So in the exclusion diet, the child is allowed to eat solid food, whereas a list is given which is allowed to eat items from that food. And so that food plus 50% from formula vis-a-vis only the formula, it was found that the Crohn's disease exclusion diet plus the partial enteral nutrition was better tolerated than the exclusive enteral nutrition in children with mild to moderate Crohn's disease, and it induced remission in a higher proportion of patients to the tune of 80 to 85% rather than exclusive enteral nutrition. Therefore, it's very relevant that we start thinking about it and start using either Crohn's disease exclusion diet or exclusive enteral nutrition in combination, either as a monotherapy or for drug de-escalation therapy. And it has also been found to be useful in patients who are becoming refractory to biologics as a salvage treatment. And this has been shown to be successful in about 60% of the patients. So to conclude, I would like to say that pediatric inflammatory bowel disease is increasingly being recognized in India, especially in the last decade. Crohn's disease is more common in the south, whereas ulcerative colitis is more common in the north. Overall, the disease location and phenotype of PIBD in Indian children is similar to the West, but familial IBD is less common in India as compared to the Western population. Nearly about 15 to 20% of our patients are diagnosed at less than 6 years of age, which is the VO-IBD group, and these children have higher prevalence of IBDU, more colonic involvement, more severe disease, and that is why a stepwise evaluation of the disease extent, the upper small bowel and the colon, and also a stepwise evaluation of this very early onset IBD group, including genetics, is essential for a correct diagnosis so that you can identify those who have a monogenic disorder. The therapeutic options of enteral nutrition, biologic, and surgeries are underutilized in our country, and we need to make an effort for an early diagnosis of PIBD and early use of biologics in the high risk group of Crohn's disease. We need to look at enteral nutrition and stool therapy or as in situation. And while we are treating children with IBD, a serial monitoring for response and growth is essential. And apart from clinical evaluation, if we include CRP or inflammatory markers and fecal calprotectin along with the clinical evaluation, it gives a better assessment of the mucosal A holistic management of the children with PIBD is essential, with attention to nutrition, growth, vaccination, social well-being, and a proper transition to the adult services when they reach around 18 to 20 years of age. And there's a very strong need of multicentric prospective studies for better definition of PIBD in our country. Thank you very much for the patient listening. Thank you.
Good afternoon, everybody. At the outset, I must thank Dr. Manoj Sahu and Dr. Avinash for giving me this opportunity to speak at the midterm Endocon. It's a different format. It's all virtual, but at least we get to meet and connect and learn science. The topic for today is endoscopy in inflammatory bowel disease. Now, as you can see, there is a big armamentarium of technologies available for endoscopy or endoscopic evaluation of inflammatory bowel disease. It starts from the simple upper GI endoscopy to colonoscopy, enteroscopy, capsule endoscopy, the newer imaging technologies today, and finally, artificial intelligence, computer-aided technology to really help us understand or assess the disease better. There is this established role, therefore, of endoscopy in IBD. Number one, initial diagnosis for the extent and severity of lesion, monitoring therapy, whether there is mucosal healing or not, therapeutic interventions today, not only just mere stricture dilatation, but we are expanding beyond. And of course, early detection of dysplasia and cancer surveillance. So endoscopy actually was a game changer in IBD management. And if you see this, the role of endoscopic examination of the bowel has evolved continuously since the first description of the utility of sigmoidoscopy for the diagnostic workup and subsequent follow-up of patients in the famous True Love and Wits trial. That changed. That's how steroids came in, and we came to know that steroids could heal. So colonoscopy is essential for diagnosis. It has given us an insight into the colon, and as simple as with one procedure from normal colon, we can say whether it is ulcerative colitis or Crohn's disease. It enables us differential diagnosis. Not only do we see, we can get tissue for the pathologist to see. The biopsy, which actually aids in the differential diagnosis of IBD. We can assess the extent of disease. This is ulcerative colitis. You go in and you can say whether it's pancolitis, so left-sided colitis, or proctosigmoiditis. You see this image. There is left-sided ulcerative colitis, and you can see a standard normal demarcation line. Based on this, you can decide what form of management will be helpful for this patient, whether it will be only enemas or suppositories or combination, depends on what you see. We can grade for severity of disease. It could be just mild disease, as you see on your left side, moderately severe, or severe disease. Accordingly, numerous indices have now been developed. I'll not get into the details of this. There are many such. The Mayo score is the one which is most used, such that between endoscopists, we can understand. And when we recheck the colon, we can compare. So 0 is normal or inactive disease, mild disease, moderate disease, and severe disease if there is spontaneous bleeding or ulceration when you see inside. There is the UCEIS score, and as I said, there are many scores which have been used, but Mayo is perhaps the one which is most common. Similarly, for Crohn's disease, you can assess the extent of disease, the areas of involvement, assess the severity. Here again, the simple endoscopic score in Crohn's disease, you assess the ulcer, the ulcerated surface, affected surface, and the amount of affected surface, the narrowing, whether it is none or no narrowing, or single passable stricture, multiple passable strictures, or impassable. Accordingly, you can assess the severity. And ultimately, if you can assess the severity, you can manage accordingly. Management is always based on extent and severity of the disease. An important area after that is monitoring of treatment. Once we see such severe disease as you see, we initiate treatment. We need to know, is or the ulcers healing? Is the patient really feeling better? When he says he is feeling better, are there still ulcers left behind? And as you can see, this is what every endoscopist would look for, that you recheck the colon post-treatment and assess for complete healing or mucosal healing. That again you can help you to decide what level of treatment will be needed in the future. Monitoring post-operative recurrence. We do a surgery for a Crohn's disease. We start treatment to prevent post-operative recurrence. But we cannot wait for another stricture to develop, another surgery. So we need to check. And there again, it is endoscopy in IBD, the Rutgers famous score of I0, I1 with less than 5 aphthous lesions, I2 with more, diffuse aphthous ileitis, and of course, large ulcers, I4. Evolution of treatment goals therefore has happened with the advent of such easy technology to assess the colon. Today, we don't wait for only improved symptoms or mere clinical remission. We are looking for mucosal healing, deep remission, and we feel, and the current trends are, that perhaps that will change the course of disease. And how do we do it? The factors: timing, target, treat to target, reach that deep remission. And how do we track it? Realization of remission, sustenance of remission is only by endoscopic evaluation. A treat to target approach leads to superior outcomes. This was a famous study recently completed, the CALM study, in which it was clearly shown that at 48 weeks since randomization, patients who were treated to target and mucosal healing was achieved were the ones who fared much better with no deep ulcerations and CDAIS less than 4. I'll spend a little bit of time on the small bowel because this is where the endoscopy has evolved to. After colonoscopy and upper GI endoscopy, the small bowel was like that deep tunnel. We did not know what was going on, but that changed with the available of various deep enteroscopy technologies and as well as the capsule endoscopy. And if you see here, how easy you can see why there is bleed, whether there is an ulcer there or not, and take decisions of management accordingly. Therapy for any form of small bowel disease can actually avoid a major surgery. And we'll come to the therapy part of it later. Spiral enteroscopy, a new technology in the field. If you can see, you can actually go from the mouth down to the colon by a single sitting and assess the entire small bowel. And you can see Dr. Mohan here, how he's doing the spiral enteroscopy and giving us a view of the entire small bowel. Comparison between the three enteroscopic techniques: there is single balloon, there is double balloon, there is spirus. Primarily, they are all similar, but perhaps the spirus has the greatest length that can be achieved. Of course, it is done under higher sedation or general anesthesia, but still, for cases in which you are avoiding surgery, there is a bleed, and you need to tackle it, it can really work wonders. So the role of enteroscopy in Crohn's disease, it has allowed diagnosis, enabled biopsy, and therapeutic interventions like hemostasis or stricture dilatation. Then, of course, the capsule endoscopy. Many patients prefer this if there is no stricture. Of course, unexplained disease, we do the capsule endoscopy. We have to be careful. If there is a stricture, we cannot do it. The incremental diagnostic yield increased. We identified small ulcers, and then there were many mild cases of Crohn's disease which improved, but at the same time, non-specific findings also increased, and hence there were, which is significant. So there was the Lewis score which came. Then there was the capsule endoscopy Crohn's disease activity index based on the findings of villus edema, ulcer, stenosis, stricture, extent of disease. Both are comparable in performance, and any one can actually be used. We then come to the new and evolving area, therapeutic endoscopic procedures in IBD. The most common and the first is stricture formation is common, and endoscopic balloon dilation has been done. The emerging techniques are endoscopic electroincision and then stenting for selected cases. For this, the pre-procedural preparation is important. We need to have a CTE or MRE before intervention, optimal bowel preparation, monitored anesthesia care or GA for patients undergoing deep enteroscopy, fluoroscopic guidance with complex strictures or multiple long strictures. Carbon dioxide insufflation is needed. Concomitant medications is again important. Systemic corticosteroid could be associated with an increased risk of complications. Biologics, however, can be continued, but antithrombotic agents should be discontinued. With this pre-procedural preparation, endoscopic balloon dilatation is efficacious. It's efficacious for primary or anastomotic strictures, for small number in close proximity, those strictures. If the strictures in general are not endoscopically transversible, balloon dilatation can be done. Small caliber endoscopes with higher flexibility is often preferred because that gives a good grip. Graded balloon dilatation is done to a maximum of 18 to 20 millimeter. Wire guided balloons recommended for high grade angulated or non-transversible strictures. What we should do as a routine is a biopsy of the stricture should always be taken at the index balloon dilatation. Concurrent intralesional steroid injection is now generally not recommended. Also, balloon dilatation should be avoided for strictures with deep ulcerations, strictures with pre-stenotic luminal dilatation, or concurrent fistula or abscesses adjacent to the intestinal strictures. Endoscopic electroincision. This particularly works for, if you know, anorectal strictures. You can see in the picture here, I think Boshen and his group has actually done a lot of work in this area and can be made using various knives. Electro incisions are made using the endocut mode, and you can see how nicely it opens up. In select cases, fully covered removable metal stents have been attempted, but as I said, this is the evolving area. The other evolving areas are endoscopic management of fistulas and abscesses. So depending on the fistula location, number, length, complexity, associated bowel inflammation, we can decide whether an endoscopic treatment is possible or not. So the main principles would be to open the fistula tract, to close the feeding side or primary opening of the fistula, example with an endoscopic clipping, keeping the exit orifice, that is the secondary opening, or to fill up the tract with certain agents like fibrin glue or plug. Varied results regarding the fibrin glue, but still these are, as I said, upcoming things which are being done. So endoscopic fistulotomy, if you see that, this is a picture of a patient with a region fistula, and it is just being anastomosis.
Ma'am, sorry to interrupt. Hello?
Yeah.
Ma'am, sorry to interrupt, but then you just got stuck for a couple of moments. I think for 2 minutes, you'll probably have to redo this slide. We will edit it.
Okay, which slide? This slide?
This slide, ma'am. Ekta, this slide, right?
Yes, this one only.
Yeah.
Can you see me now?
Yeah, ma'am. Pretty audible. It was just, it was getting stuck and we couldn't hear you properly. It was lagging a lot.
Okay.
Yeah.
Similarly, nowadays endoscopic drainage has been attempted via the for fistulas and ceton placement, via guided ceton placement. You use a biopsy forceps to grab the tip of the jag wire introduced from the external opening to the internal opening of fistula tract and tighten it with a ceton. Similarly, endoscopic clipping of pouch vaginal fistula. These are rare, complications, but once it happens, other than surgery, we had limited options, and this is again, work is being done, and hopefully, endoscopically, we will be able to avoid major surgeries. We come to colonoscopic surveillance and monitoring. We know that risk of colorectal cancer in IBD is elevated, highest in ulcerative colitis, followed by Crohn's disease, and you can see the difference from the general population. The cumulative risk of this increases over time, and by 30 years, at least 18% or 18 to 1/5 of patients may develop a colorectal cancer. So there has to be surveillance. We need to check. So there are no control trials. Most of the guidelines are based on clinical experience, but primarily they agree that after 7 or 8 years, for all UC, we need surveillance at diagnosis if there is primary sclerosing cholangitis, because that increases the risk. So random biopsy protocol was suggested by AGA and ACG, surveillance based on risk stratification by the BSG. Ultimately, all agree, whatever it is, if the disease is more than 7 to 8 years, the patient is much better off with a surveillance colonoscopy, particularly relevant for our country because colonoscopy is not that expensive, and it may be worthwhile having a check and then ensuring, because newer techniques are available. The patient need not go for colectomy all the time that there is a dysplasia. Technologies like endoscopic mucosal resection, endoscopic ESD, are the new options which can be used particularly for unifocal dysplasia. So you can see the scenic international consensus statement. Dysplasia should be characterized as resectable, endoscopically resectable, or non-endoscopically resectable. After complete endoscopic removal, surveillance recommended rather than colectomy. After complete endoscopic removal of non-polypoid dysplasia, again, surveillance is suggested rather than colectomy. So you can just maintain the surveillance colonoscopy rather than going for a major surgery. So initial screening colonoscopy after 8 years, no dysplasia, surveillance in 1 to 2 years, indefinite repeat surveillance at 3 to 6 months, flat dysplasia, you can either unifocal, you can repeat surveillance at 3 to 6 months, multifocal, low-grade dysplasia or high-grade dysplasia, patient should go for colectomy. DAM is now not used much, but if it is non-adenoma-like or adenoma-like lesions, polypectomy can be done and repeat surveillance in 6 months, but non-adenoma-like goes for colectomy. Endoscopy in IBD, there are of course opportunities for improvement. What the old facts were that the patients were at risk of chronic inflammation, surveillance colonoscopy, detect dysplasia, go for colectomy. If there is cancer, secondary prevention, and then finally. But now there are recent advanced of relapse by doing advanced imaging that will this patient relapse? Avoid unnecessary biopsies, not the random biopsy anymore, targeted biopsy. Early detection, easy surveillance, EMR, EST if needed. Real time, if possible, the pathology also while you're doing it. So step forward was chromoendoscopy, using of dyes. You can actually characterize the lesion and detect the lesion much better. Indigo carmine, methylene blue are the ones that have been used. So initially a pan chromoendoscopy with a dilute solution followed by targeted chromoendoscopy if you identify a lesion for lesion characterization. So the practical matter, if you're doing dye spray, it's messy, labor intensive. There is the question of unequal distribution of dye, as you can see over here, issues of preparation and inflammation. So easy detection of flat lesions. If you see here, it is possible, but chromoendoscopy yields more dysplasia than conventional. But to avoid that messiness, digital chromoendoscopy or narrowband imaging available at the switch of a button is what would be preferred. And if you see here on white light endoscopy, you can barely see anything. And then on narrowband, you can clearly identify the lesion as you're seeing here. And that helps us in inflammatory bowel disease diagnosis. This was a case long time ago. But that's how I got interested in, advanced imaging. This is a patient doing the rounds, no treatment, nothing was working. And then on narrowband, we identified the fine linear ulcer and diagnosed it as a case of Crohn's disease. Again, the scenic recommendations, high definition better than standard definition, narrowband imaging, not a replacement for chromoendoscopy yet, but many Japanese studies now say that this is much easier and more applicable for our practice where there is always time is a factor. Then we come to confocal endomicroscopy. As I said, can we see much better while we are doing colonoscopy? And that is confocal. So if this is the normal colonic mucosa seen by the pathologist, if we are using confocal endomicroscopy during colonoscopy, we will see something like this. So this is almost what the pathologist sees and can help us take decisions then and there. Where to take biopsy from, whether to remove it or not. It correlates well with histology. If you see here, normal crypts and then tortuous crypts, seen in a hyperplastic polyp. Advances now, computer-aided diagnosis. This is a recent paper this year which says that application of an innovative illumination with a single wavelength monochromatic light source. Okay, this endoscopic system is the first that optically visualizes the pericryptal vessels and gives us a computer-aided diagnosis for scoring histologic remission in ulcerative colitis. These are developments which are going to change the field. Artificial intelligence in IBD endoscopy. It is reaching the headlines of journals. The EndoBrain from Olympus is already available. It actually, while you are doing the colonoscopy, will tell you, as you can see here, neoplastic, high confidence, probability of 99%. So a lot of our headaches and tasks are gone. It is a constant help with us, if not everything also. If the EndoBrain suggests that this area is possibly neoplastic, we can take biopsies then and there, and in fact go in for therapy immediately. After all this endoscopy discussion, nothing can end to nowadays without the COVID-19 story. After COVID-19, endoscopy in inflammatory bowel disease, what should we do? Suspected new diagnosis of IBD. First, rule out COVID-19. No diagnosis, first do a Clostridium difficile. If it is negative, rule out IBS, meaning thereby colonoscopy comes later. Do fecal calprotectin. Try and see if you can avoid a colonoscopy during the pandemic. If there is a severe acute flare of ulcerative colitis, again, rule out COVID-19. After ruling out COVID-19, then do a stool test to rule out any other gastrointestinal infection. Test for C. diff, test for CMV. If it is a confirmed diagnosis of flare-up, also assess had the patient had a colonoscopy in the previous 3 months. Only if there is no colonoscopy in the previous 3 months, possibly you should go for a sigmoidoscopy. Otherwise, admit the patient and start treatment with steroids, with higher level medications, and if doesn't respond, only then go for a colonoscopy. Similarly, for obstructive features, go for abdominal CT, MRI, assess for COVID-19, and then take diagnosis. Overall, whatever be it, new diagnosis of IBD, severe acute flare-up of ulcerative colitis, or partial colonic obstruction in patients with IBD, rule out COVID-19. Colonoscopy should not be routine. Colonoscopy only in need, and if needed, carefully with full protection in a dedicated endoscopy room, negative pressure room preferred. If not available, wait 1 hour with open windows before and after the endoscopy. Wear your PPEs, take your self-protection as well. In addition, never allow relatives and caregivers and patients should also wear facial mask and possibly gloves. So the key messages today are endoscopy plays a fundamental role in the diagnosis, management, and treatment of IBD, we know. Small bowel evaluation nowadays has become easier with the deep enteroscopy technologies available. And that has changed our management of IBD as well. There is an increased risk of colorectal cancer in long-standing IBD. Surveillance colonoscopy aims to detect dysplasia, early cancer, and reduce morbidity and mortality by simple colonoscopic procedures like EMR or EST. Therapeutic endoscopy is now expanding beyond stricter dilatation to fistulectomy, abscess drainage, use of stents, and as I mentioned, EMR and EST. Advanced endoscopic techniques, including computer-aided AI systems, have the potential to improve dysplasia detection, target biopsies, and ultimately, all this will help to improve outcomes for a chronic, lifelong condition like IBD. We are yet to see the future. The robot may tell us. Now, I thank you for your attention.
Thank you. I would like the panelists to unmute their mics. We will start the panel discussion. The first question has come to Dr. Anshu Srivastav. What should be the basic screening tests that we have to do to rule out immunodeficiency in a child with chronic diarrhea?
See, there is no one standard test which we can say that if you have done this, all immunodeficiency disorders have ruled out. The first and most important thing is the history. Any child who has got immunodeficiency, we are not talking here only of the IBD. They'll have recurrent infections, they'll have infections at different sites, they'll be requiring more courses of antibiotics and all those things. So that is a suggestion that this child is prone. Second is, if you're talking of the VOIBD group, then as I mentioned that if there is an onset which is definitely below 1 year, or I would say 2 years, and especially if you say that the younger the onset, if you have a child who's having an onset at 2 months, they're more likely. So it's that age group. Plus, if you find all those signs that they are atypical infections, there's hepatosplenomegaly, there is arthritis and all those things, and there is no response to the standard treatment, that's a subgroup with a high suspicion. And we will start, like if you say I have a 8-year-old child or a 6-year-old child and who's presenting just normally, I would perhaps do a retrovirus, I would just do a immunoglobulin profile, and I would look at the T cells, and that's it, number. I don't need to go beyond it. But if I'm getting clues, or if I have this high risk group, then I will definitely do the immunoglobulin profile, IgG, A, M, and E. We would ask for the DHR test, which we do for the chronic granulomatous disease. If we find clues, like if I find IgE levels are raised and there are thrombocytopenia, as I showed you, I would go for the viscotalric gene. So it depends upon the clinical manifestation and how strongly we are suspecting. And this is where we utilize our immunology colleagues always, because they come in and we together decide, okay, this child first strata, level 2, level 3, level 4. Now you are treating and simultaneously you are finding that the patient is not responding and he's developing new fistulae. You have started all immunosuppression, you're giving biologics, he's still not responding, and he had an onset at 2 or 3 years of age. Then my alert bells will start ringing. No, this is may not be. So I may even start for an NGS and ask the child's family to spend 20,000 rupees and get an NGS panel for these monogenic disorders straight away. Because many a times asking for independent tests may not be even maybe more time consuming and turn out to be more expensive in the long run. So, but if it has to be case based, I can't prescribe that, okay, do this and it is done. But definitely ask for an immunoglobulin profile in all patients, definitely rule out retrovirus infection in all patients, because we have seen even younger patients, 2 years old, who are presenting with diarrhea and they have this kind of a thing, and then go case wise.
Okay. The other question is, some of our younger adults who are suffering with IBD have a question as to what is the risk of my child developing IBD if one parent or if both parents have inflammatory bowel disease.
Definitely the risk is higher. If you have a family history of IBD, definitely the risk is higher. And for that, actually right now they are doing the studies where they are trying to manipulate the gut flora. The meconium study and all those things are on, where they are trying to manipulate the gut flora of the pregnant woman so as to see whether the risk of transmission to the child of the mother who has IBD is going down or not. But there is no prophylactic therapy which has to be offered at this point of time. So we have to counsel them that there may be an increased risk, but I don't think they have to worry that much about it when they are asymptomatic.
No,
Dr. Rupa, you wanted to add to that?
Like to, yeah, I just thought I'd just add a few words. We actually, for our patient population, we've just published in about the family history of IBD. And I think with a large number of patients of more population, the family history is much lower than what is being reported from the studies. So I think it is important because when you are talking to the young adults, ours is ranging between 4 and 5%, whereas for Western studies, and I think will agree with me, there are many IBD separately to most of the pediatric IBD patients, not most, a larger number will be having a family history compared to the adult onset IBD. So it depends on the onset of IBD. So younger onset IBD or pediatric IBD, the incidence of family history is higher. But when you are counseling a patient, the possibility of their child developing IBD, you should not tell them that you should not plan because the risk is much lower compared to other studies reported.
Okay. The other question raised is how do we improve compliance to enteral nutrition in children? Is there a role of prophylactic placement of a PEG or long-term nasogastric or nasoenteric feeds?
See, when we are giving exclusive enteral nutrition, and that's the reason it has not taken up in our country in that big sense, because it needs a total dedication for 8 weeks. So if you have a child, where what I experienced when I was outside was that they used to place an NG, but never a PEG, because this is not a permanent thing that you are asking for. So it's an 8 weeks, and by the end of 3 to 4 weeks, you will get an assessment whether the patient is responding or not responding. So in that case, if you have an older child and the child is dedicated, there's no need for an NG. But if you have a child where you have plus minus, then you may need to put an NG and feed that. But PEG definitely we don't ask for.
Dr. Basumani, this is a question to you. What are some of the mimics of IBD on colonoscopy that you have seen in your practice and that endoscopists have to be wary about before the diagnostic inflammatory bowel disease?
Thank you, Amit. Thanks to Rupa and Anshu for excellent presentations. Real treat. So, right from tuberculosis in various places, from ileum to ascending colon, chronic NSAID use. People who have abused NSAID for many years for headaches and other pains. Even people on isoretinoin for acne treatment. Isoretinoin mimicking Crohn's disease like aphthous ulcers. In the olden days, gold and other disease-modifying agents can cause. Even glutaraldehyde, the one we use to clean the scopes. I've had patients who had normal colonoscopy day 1. Day 5 had a florid fulminant colitis due to glutaraldehyde. I've seen people with, of course, Clostridium difficile and antibiotic-associated colitis. Ischemic colitis is a very classic mimicker of segmental colitis, but the watershed zone and classic distribution and preceding severe pain due to migraine or mesenteric vascular event. I've seen post-radiation colitis mimicking IBD. All this I'm recalling from my own personal series. So these are some of the things. Of course, tuberculosis comes first in the differential diagnosis. CMC Vellore has published a lot of papers distinguishing radiological, endoscopic, and microscopic features. But at the end of the day, you have maybe this or maybe that this clinical conundrum where you carefully exhibit ATT trial and take a stock taking colonoscopy and clinical assessment in 3 to 6 months time. If the lesion disappear and patient doing well, carry on. Otherwise, revisit the possibility of Crohn's disease. Very rarely I've been misled by even lymphoma and adenocarcinoma of the ileum mimicking IBD. We have taken for granted without histological proof. The biopsy was not deep enough to give the diagnosis, but during the clinical progress. So IBD is not a pathognomonic, a sine qua non disease. You take everything into picture, clinical, radiological, endoscopic, as well as biopsy. When histology is not, and the index ileocolonoscopy is not dogmatic, is not diagnostic, please keep an open mind and don't be let down in the garden path.
Okay. Sridhar, you are in an academic center at KM Hospital. What is the grading that you use for grading ulcerative colitis in your unit? And do you use the Mayo score or UCIS? And why do you prefer one over the other?
Thank you, Amit. Thank you. So we at KM started using UCIS around 3 years back. We were using Mayo before that. Only thing, the amount of overlap that you see in the Mayo grading is a little. I mean, it's not as objective as the UCIS is. So we started using the UCIS. Now, clearly, the Mayo has the advantage of having some clinical scoring as well. But I mean, these are the history and is something that you obviously take for the patient. So the UCIS is more objective when you're coming to grading the severity of the disease, which is why we started around 3 years back, changed over to the UCIS.
Okay.
And UCIS is the most validated
Absolutely.
one.
Absolutely.
It is the
Absolutely.
only validated questionnaire. So it is a little difficult, but if you're planning to write papers, I think Dr. Sridhar would be thinking the same, that if you are planning to write, it is better to have a UCI score.
Yeah. Yes, ma'am.
When it comes to small bowel Crohn's, Dr. Rupa, this question is for you. Are you happy to make the diagnosis based on imaging, or do you want a small bowel enteroscopy in all these patients?
I would prefer to have an enteroscopy, but enteroscopy is not available at all centers, and we have to be keep that in mind. But in our center, we would definitely prefer to have an enteroscopy because it gives us the first time what is the status. But later on, we do not follow up with repeat enteroscopies. Okay. So the first impression, the first biopsy, the first look, we do it. The other is we have therapeutic procedures available now. So multiple strictures in the small bowel, you'd rather go for enteroscopic dilatation and at least see how tight the strictures, whether it can be dilated or not, and save surgery. Because in Crohn's disease, you should not go for a surgery, I think, at the drop of a hat, particularly for extensive small bowel disease. So that is the reason why I'd prefer to go for an enteroscopy and then evaluate and treat accordingly.
The other scenario that we face is that of post-operative Crohn's. Dr. Shenoy, in your practice, when do you scope the patient after surgery for Crohn's disease?
Hardly I have subjected only 1 or 2 patients for a surgery where initially we had a diagnostic problem, dilemma. The patient had come with the intestinal obstruction. Usually suggest after 6 to 12 months, where you expect around 1/3 to 1/4 of them having a recurrence as such. Subsequently 10%, because Crohn's is a chronic and relapsing disease. You need to educate the patient that it's not the end of the treatment, that surgery is not the end of the treatment. You need to continue the follow-up as such, that needs a proper surveillance.
Dr. Anshu, now we are moving the targets to mucosal healing and histological healing. In children, sometimes it is difficult to do colonoscopies frequently. So how do you follow up your patients? How do you see that targets are met?
We do always, for documenting as a gold standard mucosal healing, definitely we need to resort to colonoscopy. So it's not that we will do a colonoscopy and make a diagnosis, then follow them clinically, follow their CRP, follow their fecal calprotectin. Once we are reasonably sure that, okay, he's been in remission for a significant amount of time, and so now it's like about 1 year down the diagnosis, the child has been very stable, doing very good, then we will repeat a colonoscopy, but not at every 3 months. And obviously that would depend upon the age of the child. If a child is 12, 13 years, we are more easier to do it. But if a child is 2 years old, then we would want a longer period of confidence that yes, the child has been doing well before we subject him to that. But we do use colonoscopy to document mucosal healing because we have to take biopsies also at that point of time.
Yeah, Dr. Shenoy, you want to make a point?
Dr. Just wanted to ask you, what difficulties have you faced, whether child coming with whether those like fistula and all, whether it is a Crohn's disease or tuberculosis, what exactly you do, whether you start them on ATT or something or follow them up. So
See,
since you know,
that dilemma of tuberculosis and Crohn's disease is always there, but we have not seen any fistulizing disease with tuberculosis. At least in my experience, we have not seen. And we had analyzed our children with tuberculosis versus Crohn's, and we had found that presentation with rectal bleeding and left-sided colonic involvement were the two things which were taking us on multivariate towards a Crohn's disease. But otherwise, the differentiation is just like you do in adults, like we make all efforts to take tissue diagnosis. And in that scenario, if you are still stuck, we treat them with ATT response, monitor the response, repeat the colonoscopy or the small bowel imaging after 3 months, look for remission, and then go from there. There is an added component of MDR, which has now started coming up, and we are experiencing adolescents, 14, 15 years old, who are having MDR tuberculosis. And that is complicating the issue because the child is not responding. Now, the step 2 question is this MDR or is this Crohn's disease? So we have had 10 to 20% of our patients who have received ATT, then gone on to even MDR and then gone to Crohn's. So it's many a times, because it's not that even if you do gene expert and everything, we get in almost like 20 to 25%, you'll get AFB seen. Otherwise, it's all clinical and investigative, not documenting the tubercular bacteria that the diagnosis is made. So we suffer the same problems just like that of the adults. But luckily, we are not seeing this intestinal tuberculosis in children who are less than 4 or 5 years of age. It's extremely uncommon. So that group is spared up till now.
Okay, so this is our last question for the day. Sridhar, I know that you are doing some work in cancer screening in IBD. Can you share with us what your protocol is for patients with IBD where you do the cancer screening?
Actually, this is something that we surveyed last year. We conducted a survey with the Indian Society of Gastroenterology for gastroenterologists and looked at image-enhanced endoscopy practices in the colon. And this was one of the questions wherein we looked at cancer surveillance in IBD. So we found that 36% used NBI, 24% used random sampling. And as Madam already mentioned, chromoendoscopy has a role, but only 11% actually use chromoendoscopy. So I mean, chromoendoscopy is still not used, but in our center, we use chromoendoscopy. I use methylene blue to do surveillance colonoscopies for patients with IBD. I think already the protocol was mentioned by Madam, but I found there was a distinct advantage of using methylene blue. We've had, at least in the last year, 3 patients who we diagnosed with an early lesion in the background of an IBD. So yeah, there is clearly an advantage of using chromo, although in practice it becomes a little more cumbersome. It's difficult and especially requires some amount of training because not everyone is really used to using dyes. Not everyone is akin to spending more time or doing a colonoscopy. Maybe it adds another half an hour, 45 minutes to the procedure. So that is one thing. That is one thing that I felt. So, but chromoendoscopy is the way to go.
Dr. Rupa, you want to comment on that? NBI versus chromoendoscopy? I think we've lost contact. I think we'll stop here. We've had a good session where a lot of queries have come out, a lot of questions have come out. We've had a good discussion on important topics that we don't generally come around. Pediatric IBD is a huge topic, and thank you to Dr. Anshu and Dr. Rupa for enlightening us on these topics. Thank you.
Thank you.
Thank you. Thank you.
Thank you, everybody.
Thank you, ma'am. Thank you.